Hello, everyone. I'm gonna go ahead and just get rolling just
Hey,
for
Jen.
hello. Oh, I'm gonna go ahead and just get rolling for the sake of time, just so that we can stay on top here. Um, I'm Natalie, as I will show you in the previous slide, next slide. My name is Natalie. I am a medical student at MCW. And I will be the one presenting tonight, kind of about breast cancer specifically. Um, Obviously, I work with Motivate MD, and this is my fourth cycle doing it. We are in interview season for those who are currently applying. So I'm doing mostly mock interviews right now, but I do everything with the cycle. So I'm very well versed in how it all kind of goes. Like I said, I'm in my last year of medical school, so I'll be applying to residency in the next couple weeks, and I'll be applying combined internal medicine and pediatrics. So I'll be double board certified by the end of it, which will be great. I'll get to treat everybody in the hospital, so I'm looking forward to it. Um, but without further ado, we will get right to our topic here. Um, or first, we'll go over the session outline, and then we'll do a little bit of a poll, and then we'll get into our topic. So for those who are wanting to receive kind of your credit for attendance here, feel free to go ahead and scan this QR code. The session outline will be very similar for how these have run in the past. So we'll go over the case and the physical exam, differential diagnosis, real short assessment and plan, and then go a little bit more into the pathology of breast cancer because it's very applicable to like biology and biochem. And so hope we can talk a little bit more about that specifically. But first, we'll go ahead and start off with a little baby pool. Um, let's see. Hopefully it'll launch for everybody. Let me know if you can't see it. But oh, okay. I'm curious. So I'm not sure if you guys, there's probably a way for me to actually share this with you, but most people, it looks like the temperature drop is what they're most excited for, which is amazing. Yes, I'm a big fan of the temperature drop. But then we also have Halloween, and then somebody has other, and I'm kind of curious what the other is, if the person would like to share. If not, no worries. We'll just keep moving on. All right, we'll keep going. Cool. All right, here's that QR code again, just in case you didn't get it the first time, to make sure that you have it now. Oh, somebody's in the chat. Apple cider. Yes, apple cider is amazing. I love apple cider. Big fan of apple orchards. Yeah, it's great. Warm apple cider donuts. It's great. I love fall, but hence why I asked the question. Okay, back to the task at hand though. Um, Again, if you need the QR code, here it is for you. Go ahead and scan it, take a look. I think it'll be at the end of the presentation as well, but I'll give a couple more seconds just to make sure so that everybody can get the credit where they'd like to. All right. Hopefully everybody's got it by now because we're gonna get rolling. All right. So our case for today is Mrs. L. She's a 56-year-old female. She's got past medical history of hypertension, which is high blood pressure, polycystic ovarian syndrome, and eczema, presenting after noticing a lump on her right breast. Um, and so some of this will be a little bit of review from 2 weeks ago when I presented, but this is essentially what I would call our one-liner, or some people will call it a flexible problem representation. And it's supposed to sort of demonstrate the most basic and foundational knowledge about a patient who's coming in as you're trying to communicate about them. And there's really three big main components. The first part being the patient demographics. So we have a 56-year-old female. So we know immediately from that that she's in an older age bracket. She's probably postmenopausal, which is important for like this specific patient, essentially. And there's the diseases of the young. She's probably past. So we worry about bigger, scarier things as people get older. The next part being past medical history that may or may not be relevant, which again, you will kind of learn as you go throughout training what things are relevant and what things might not be relevant. It takes a little bit of learning, so it's always easier to just err on the side of caution when you're first in your training. And then the last bit being why they're here today. And for our patient, that is, of course, because she noticed this lump on her right breast. Okay, so a little bit more about her. So just for history, Mrs. L, again, is a 56-year-old female. She's got a past medical history of hypertension, PCOS, and eczema, who presented after finding this lump on her right breast. She reports that she noticed the lump while showering about a month ago and now has some associated tenderness. She doesn't think it's changed in size at all since she discovered it, but she's very concerned. She does not remember having any trauma to the area, though she does work with primary school children, so it's potential. Kids are little and like to jump all over stuff. And she hasn't noticed any redness, swelling, or streaking in the area. Her nipples haven't changed in appearance. And otherwise, she's been in relatively good health without any recent fevers, upper respiratory infection symptoms, chest pain, shortness of breath, abdominal pain, nausea, vomiting, diarrhea, constipation. Also notably, her last mammogram was 2 years ago and it was normal. And she previously hasn't had any abnormal mammograms. Okay. So this is like very baseline information, kind of that first time you're meeting somebody, asking questions, getting the story. This is the sort of stuff you might get. But for a patient like this, who, I'm immediately a little bit more concerned, because she is in the age bracket where many women develop breast cancer, which is usually postmenopausal. Frequently, I think it's generally in your 60s is the peak of when it happens. It can happen anytime, of course, but she's in that bracket where it's becoming more common. And so we just always have to err on the side of caution. So I want to do a little bit more investigation into what exactly has been going on, and is there anything else that I kind of really need to know specifically regarding my concern for a potential cancer in this patient. So of course, there's lots of other things we should always know about people, but specifically for her, we'll need to ask about her gynecologic and obstetric history, her past medical history, surgical history, family history, which is most important for concerns for like cancer syndromes that are running in families, and then social history as well. Okay. And so I'm going to break it down because we do need to cover it. And for her, I can't quite just say, oh, no, it doesn't matter. For this patient in particular, we need to know about all of these other things going on with her that can be contributing to this picture. And a lot of the questions that we ask when somebody comes in with a new lump and we are concerned about a suspicion for a cancer are questions that are oriented at gauging somebody's risk factors. So there are certain components of somebody's history that we know from the many, many decades of research we have done on breast cancer that can predispose people to developing it or can exacerbate it, and so on and so forth. And so we ask these questions to essentially anybody who comes in who we're concerned about seeing a breast cancer in. So like I said earlier, gynecologic, obstetric, past medical history, surgical, family, and social history. So for our patient, regarding her gynecologic and obstetric history, her age of menarche, which, if you don't know what menarche means, it's the first period that a female patient has. And her age of menarche was 14, which is classic. That's a very common age that most women get their periods. And her age of menopause was 53, which is also within the realm of normal. We kind of expect women to start going through menopause sometime in their mid to late 40s. Most women will have completed menopause by their mid 50s. So 53 is very fair. The next bullet point here for gynecologic obstetric history is asking about hormone replacement therapy and oral contraceptive pills. Our patient has never used hormone replacement therapy. Some women, it's not It's not classically done anymore now because we have since learned that can predispose people to develop cancer, because a lot of breast cancers are fed by estrogens, so on and so forth. But it still will be prescribed for women who have like really bad menopause symptoms. So we'll have like hot flashes and mood swings and things like that. So sometimes it is still prescribed. Oral contraceptive pill use, though, is also considered a risk factor for developing breast cancer. And so for our patient, she used OCPs for about 20 years. The next thing we ask about for gynecologic obstetric history are things like her pregnancies. She is a G3P2. And what that means is that she has had 3 pregnancies and carried 2 of those pregnancies to term. So the G is how many pregnancies she's had, and P is the amount of, like, again, pregnancies she carried to term and delivered. And then the last question here is about breastfeeding. And specifically, we ask about breastfeeding not because not breastfeeding is a risk factor, but we know historically that breastfeeding is a protective factor. So women who breastfeed are at a lower risk of developing breast cancer later down the line. And the thought process behind that is that when you are breastfeeding, your menstrual cycles are not regular. So most women will stop their menstrual cycles when they are breastfeeding, at least for the first 8 to 12 months. They are not cycling regularly by any means. And it's really that pause in menstrual cycle that they think is the reason that it's this like protective factor. So again, not breastfeeding does not cause cancer. It's just that breastfeeding is a protective factor. Okay, so then in her past medical history, we've already covered it. She has hypertension, PCOS, eczema. Surgical history, we always ask about because for someone like this patient, I want to know if basically she still like has all of her parts, if she still has all of her reproductive organs, because that can play a factor in, selecting which kind of drugs to use as we're treating later down the line, so on and so forth. It also makes you think, like, if we were to discover a cancer like gene mutation in this patient, she may need to have like prophylactic surgery to have like her ovaries removed or something like that, because they can also become, mutate and become cancerous as well. But our patient hasn't had any surgeries, so she still has her uterus and her ovaries. We also, of course, ask about any other cancer surgeries as well, because prior cancer diagnosis is if somebody has had a prior cancer and then they are diagnosed with breast cancer, that's like a red flag. Whenever somebody has 2 primaries, we get worried about that. We think that there might be something else genetically going on for someone. Okay, the next thing being family history. And for this patient specifically, she has a sister with thyroid cancer, a father with pancreatic cancer, and a great aunt with breast cancer. Given this family history, this patient would probably qualify for genetic testing. And the reason that she would qualify for like genetic testing to be covered by insurance is because she has a parent, a first-degree relative with pancreatic cancer. So pancreatic cancer is both one of the most deadly cancers as well as uncommon. And so when we see it pop up, it's kind of immediate grounds to look for a genetic mutation, because it also is associated with a fair amount of, like, again, cancer gene mutations in germline. So this patient would probably qualify, like I said earlier, for insurance covered genetic testing. And then lastly, the social history for this patient. So she is a school teacher. She lives with her partner at home, drinks 2 to 3 glasses of wine a night, and has a remote 5-pack year smoking history. A 5-pack year smoking history is pretty minimal. It's of course a risk factor, absolutely, in developing cancer, but it's not. We think about it more like if you have a 20-pack year smoking history, then it's like, okay, we need to start screening you for cancers because of that. However, this patient drinks 2 to 3 glasses of alcohol a night, and that is well over the kind of recommended amount for a female. So for women, it's specifically 4 to 5 glasses a week, 4 to 5 alcoholic beverages a week. And while we don't societally think of that as being a risk factor, that is certainly a risk factor for people in developing cancer later down the line. Okay. So we'll go right into physical exam now. Vitals, your vital signs are always kind of the first component of your physical exam. So looking at our patient, she doesn't have a fever because she's at 98.5 and a fever is 100.4. Her heart rate is normal at 83. If it was over 100, then she'd be tachycardic and I would be worried. Her blood pressure is high, but she does have a history of hypertension, so I'm not immediately worried about it. And her respiratory rate is 18, which is essentially like normal breathing for most people. So overall, she's very well appearing. Her head, eyes, ear, nose, and throat look good. So her pupils are equal and reactive to light. Her extraocular movements are intact. She doesn't have any scleral icterus, so her eyes aren't yellow. And her conjunctiva are normal, so not injected or anything. Her cardiac exam is also totally normal, so regular rate and rhythm. She doesn't have any murmurs, and her capillary refill looks good. Respiratory-wise, also looks good. She doesn't have any increased work of breathing. She's clear to auscultation bilaterally, so you can hear those lung sounds in all the lung fields, which is what we want. Okay, but now to like the more interesting part, which is her breast exam. So on the right side, she has a 3 centimeter immobile mass present at the 10 o'clock position, approximately 6 centimeters from the nipple. So no noted discharge, skin retraction, or changes to the overlying skin texture or dimpling, right, which is good. And then her left side is totally normal. Don't feel any masses, nothing is different, everything looks okay. But a part of a comprehensive breast exam is you actually examine the patient in multiple attitudes. So you'll examine them first, like sitting up, and then you'll actually examine them laying down. And that's because like breast tissue falls differently when depending on like your positioning. And so whenever you're doing a breast exam, you essentially do the same thing twice, but one time they're sitting up and the next time they're laying down. And then another part of the breast exam is actually like palpating for lymph nodes. And specifically what we're feeling for are axillary lymph nodes, so in the armpit, as well as supraclavicular lymph nodes. So those are your lymph nodes that live right here. And the reason that we specifically look in those groups is because we know that breast cancer spreads through lymphatics most frequently. And so if it's going to go anywhere, the first place it's going to go is actually somebody's armpit, because that, I'll show you a picture later on, but like that is where the lymph nodes drain first. And so that's where you're most likely to find it on an early diagnosis. So overall, when we think about what this person's breast exam is like, there's some like more red flags here, right? And the bigger ones being that this mass is over 2 centimeters. This is 3 centimeters. It's also immobile. And that's not great because when we think about a mass being immobile, we're worried that there's like, invasion kind of at deeper tissue levels. And so it won't move as much. It's also at the 10 o'clock position, about 6 centimeters from the nipple. So it's in like the upper outer quadrant, which is more concerning for a cancer than per se other reasons that women would have, like lumps and bumps, essentially. But on the good side of things, there isn't any skin retraction. There isn't any discharge, and the skin looks okay. So that essentially means like, okay, even if I'm worried about this being a cancer, it's not invading the skin yet, which is like a prognostic factor. That is a good thing, right? It's still relatively small at 3 centimeters, but it's enough that like we're going to have to check her out after this. We're going to have to do some further workup. Okay, the rest of her exam, though, is essentially normal. So her abdominal exam looks good. No scars, non-distended, non-tender. Her organs are all the right size. Great. Her musculoskeletal and skin exam, nothing wild. Doesn't have any rashes, doesn't look yellow. Great. And then her neuro and psych exam, she doesn't have any focal deficits and has normal thought and behavior. So overall, really the only alarming thing here is per se this woman's breast exam. Okay, I'm gonna pause here in case anybody has any questions so far. Feel free to either pop them in the chat or just say them out loud. All right, cool. We'll keep going then if nobody's got any questions. Okay, so we'll go into then the differential diagnosis, which is like, well, what can a breast lump or bump be? Well, there's actually a lot of things it can be, but these are the most common things. And I'll go through kind of each one and explain a little bit further in depth what they are and kind of the type of patients we find them in. So, fibrocystic changes is a very fancy way of saying when a woman is like going through her menstrual cycle, at certain points during the cycle, based on her hormone levels, she will have like her breast tissue will essentially become more edematous, so it will enlarge and can be more tender. And so fibrocystic changes is what we call that, is when somebody is like, oh my gosh, my breasts feel different. Like I think there's more bumps here, but it goes away. And they kind of see this pattern at certain points in their cycle, this is happening. And that is almost entirely attributed to just the hormone fluctuations and levels. It's a very normal thing. A lot of women experience it. And so we don't worry about it. There's nothing pathologic about it. The next thing on this list being a breast abscess or infection. Those are pretty, it seems somewhat obvious. They hurt a lot. I would say that the most common type of patient to find this in is usually a new mom breastfeeding, or not necessarily a new mom, but just a mom who's breastfeeding. Because, like, if you think about it, when you're breastfeeding, you've got this teeny tiny human with their gross mouth kind of attaching to her nipple, and it just has the possibility of introducing bacteria as a result. Breast abscesses, though, again, are like pretty clear cut. You can kind of tell when that's happening, and that's because the area will be really warm. It'll be like bright red. Sometimes there'll be streaking of that redness, like up further into her breast tissue. It's usually will be quite tender, and then it will feel what we would call fluctuant. And so what that means is when you kind of move it around, you're like, or poke it, you're like, this feels liquidy. And there is like a specific feeling to it. So it becomes very obvious. So given that our patient doesn't have a fever, doesn't have this specific like loculation that you can kind of, feel, I'm not really worried about a breast abscess here. However, breast cancer is going to be biggest on our differential, again, for the reasons that I've already kind of previously described about why this is worrisome. Like our patient has a couple risk factors. She's in the right demographic for developing breast cancer, and her exam is just like a little concerning. Again, enough so that I'm like, we definitely need to get some further tests. However, also again on this differential, the next thing being a fibroadenoma. And so a fibroadenoma is essentially almost exclusively happens after some sort of trauma has happened to the breast tissue. And so especially in areas of our body that are really essentially just fat cells, fibroadenomas can happen. And so most of a woman's breast, other than the lobules and ducts, is largely fat cells. And so if per se she were to like run into a table or a door or something and hit her breast, she'll probably get a nice bruise afterwards, but also she can have a fibroadenoma develop. And essentially that's just scar tissue. That's literally just what it is. It's like in that healing process of trying to, address the inflammation and the bruise that just happened, you can develop the scar tissue that's really fibrous and feels like a large bump or lump. Usually, people can tell you, they're like, yeah, I really hit myself like on that door, really just, and I was black and blue for a couple days. And you're like, okay, I think this is more than likely just some scar tissue, a fibroadenoma. And then lastly, on this differential is a lipoma. And so lipoma is a benign mass, again, of adipose tissue, so fat cells. And you can get lipomas literally anywhere on your body. I would say the most common are kind of on your upper back, but they can happen anywhere. And so it's benign. It's usually very wiggly and jiggly. It just feels like this globule of fat, and so that is also an option. Okay, but going into kind of what we know about this patient so far, what we've learned, again, we always start an assessment and plan off with a one-liner. So we'll return back to that foundational concept of who this patient is and what they're coming in for. And so for her, it is Miss L is a 56-year-old female with a past medical history of hypertension, PCOS, and eczema, presenting after discovering a lump on her right breast. Her exam is notable for a 3-centimeter immobile mass present at the 10 o'clock position, approximately 6 centimeters from the nipple, without associated lymphadenopathy. Our differential diagnosis includes more than likely a fibroadenoma versus malignancy. And malignancy is a very fancy word for cancer. And those are kind of the two things I would put up highest because of her like given exam, right? But the next process is working her up. So I'd like to like pose to the group, what things would you like to gather for this patient? What thoughts do y'all have? Put it in the chat. Say it out loud, whatever you're liking. All right, we'll keep going then. So again, like the biggest concern really for this patient is that she could potentially have a breast cancer, right? And so essentially the first thing we do is a mammogram, is imaging. It's a mammogram. And I'm going to show y'all pictures of a mammogram because they look a little bit different from like classic imaging. So it's worthwhile taking a look at. But the first thing we're going to do is get that mammogram to see what this mass may or may not look like on imaging. The next thing we're probably going to do, pending what her mammogram looks like, is an ultrasound and a biopsy. And then lastly, if we were concerned for metastatic disease, which means that, the cancer cells have left their local tumor and traveled somewhere else in her body, then we would do a CT scan. So if this patient had lymphadenopathy, so had swollen lymph nodes like up in her armpit, which she didn't, but if she had, we would probably do a CT scan to check out everything that's going on there, see if anything needs to be done, really. So the next question I would pose to y'all is, why do we need biopsy data? Maybe even before we do any sort of surgery, which is ultimately what this patient will have to have at some point. All right, you guys. We'll see what it says. Yeah, make sure it's definitely cancer, for sure. That is definitely a possibility. It is absolutely your confirmation, right? Like even if we see what it looks like on imaging and we really suspect it, it's good to get a biopsy to like be 100,000% sure. It is your gold standard for a diagnostic test. The other reasons for getting a biopsy is pending what these cells kind of look like underneath a microscope, or pending what hormone markers and receptors they're expressing, kind of directs us on whether or not we need to go looking for more things, or whether or not we need to be really aggressive with surgery, right? Like, do we need to do a mastectomy? So take off all the tissue in the breast. Or could we get away with just a lump, what they would call a lumpectomy? So just take out kind of that local stuff. That biopsy data helps us guide kind of that decision, essentially. And that's planning we need to know before we go into the OR. That's what the surgeon's going to want to have before they're willing to cut this person open. All righty. So I wanted to show y'all a couple pictures of mammograms, and these are positive mammograms. So these are mammograms that we are worried about breast cancer for. Um, and so for those who don't know, mammograms are actually taken in two views, right? You compress the breast tissue kind of side to side, and that's this first picture on the left here. And then you also compress it top to bottom. And so that's this next picture here. Um, and as you can see, there's like, you can see all sorts of stuff. So it's an X-ray, right? But you can see like all of these vessels. And actually the reason that you can see these vessels is because they're calcified. So this is actually an older patient more than likely because her blood vessels are pretty calcified. But then also all this white stuff is probably also little bits and pieces of calcification, which isn't immediately concerning, right? The concerning thing is this white, bright white thing that's right here. What is that, right? It doesn't look anything like the other tissue around it. And kind of the rule of thumb whenever you're looking at any sort of imaging is like tissue that looks weird is probably weird. Like if it looks like it's not supposed to be there, it's probably not supposed to be there, right? The other thing about this picture specifically is that like this is a aggressive calcification, but like this is also really dense here. It looks like there might be, this is her skin, but it looks like it might be a little bit of retraction. And those are all like red flags when we're thinking about, oh gosh, could this be cancer? Okay. However, I would say more often than not, what cancer looks like on a mammogram is this thing to the right here, right? It's actually all of these teeny tiny little itty bitty little baby dots. And maybe this is something like DCIS, which essentially is like grade, I don't even know if they call it grade 0 cancer, if it's grade or a stage 0 cancer or stage 1 cancer. But basically, these are like these are cancer cells, but they're only living in the duct. They're only living in the duct. So they haven't spread outside of the duct yet. And so the reason there's all these little teeny tiny little bright dots is because the cells will like skip places, right? It's like, oh, I'm gonna make a home right here, but then I'm gonna crawl a couple like, millimeters, right? And then I'm gonna take up space another here. And so there's like these skip lesions. And so it's these groupings of teeny tiny calcifications that make us be like, ooh, that might also be cancer. Definitely less, like lower on our staging profile, but we should probably take it out, right? We don't want it to grow. Yeah. Any questions about mammograms or like taking a look at these kind of initially? Oh, the other thing that I would point out is that you know that this was a good mammogram because they got a bit of pectoral muscle in it, right? So that's good. You know that this technician did a good job because you can see some of their pec muscle here, which is ideally what we want, because we want all the tissue to be able to see it. Because cancer will go close to the chest wall as well. Okay, we'll keep going though. So then just kind of getting into a conversation about like pathology and how it works. And so this is like very applicable to, I think, more early and basic science learning. Um, this is kind of how cancer progresses, specifically in breast cancer. And this is ductal carcinoma. So this is what like a normal duct will look like, right? You've got your like epithelial cells lining these ducts, right? Your more like parenchymal cells on the outside. And it's actually these epithelial cells that become the problem. We'll see. No worries, no worries. So as far as these ductal cells go, these are the ones that cause the problems, these epithelial cells kind of going around right here. And so basically what happens is there's this progression, right? Because you go from cancer essentially happens with a normal cell at first, right? And then slowly but surely it will gain mutations as the cells divide. And it's not until you get to a certain point where it's gained enough mutations that it actually becomes like really concerning. It becomes cancer, but it's a gradual process. It takes a long time. And breast cancer specifically is slower growing. So it just like isn't gonna be an immediate sort of thing. And so we can see this progression. So this is the DCIS that I was talking about a little bit earlier, as far as like what it is. So we know that, like I said earlier, it's contained still to the duct, right? It hasn't broken out yet. And so this is what can cause those like skip lesion calcifications that I showed on the previous exam or the previous picture. If you do not treat this, it can progress to DCIS, but outside, right? Now it's becoming even more aggressive. Now this cancer is like, hey, I'm gonna leave, right? I'm gonna investigate the stuff that's going out. I'm gonna get out of my container. And then you get into just like blatant invasive ductal carcinoma, where it just becomes kind of everywhere, really. But again, like this is a gradual process. Breast cancer, like the natural pathology of breast cancer, it takes years for this to happen, unless like you have some really, really aggressive mutations come on. Okay, and then these are kind of the paired slides to go with it. So you can initially see, like on this initial slide, you can see the duct really nicely, this like open space. So it looks totally normal. In this next picture, you're like, oh, now there's all these cells in the duct. That's not normal. And then even further, now there's all these cells in the duct and they're like breaking out, right? And they're like trying to break out. And then this last picture here, this last path slide is like, okay, now everything is everywhere, and I can't even tell you where the ducts were initially. Okay, so we'll go to the next slide. So we'll briefly talk a little bit about like, well, what are what does all this, how do you stage cancer? What does it look like? What does it mean? And so staging is based on a couple things, like I have kind of oriented in this slide. The first thing being tumor size. And so, like I said before, when I was talking about our patient's exam, our patient has a 3 centimeter tumor. So she would be a T2, right? But arguably, again, like the bigger the tumor size gets, the more concerned I'm going to be, right? But the other things that we look at are lymph node status. Um, for most cancers, it's either you can feel the lymph nodes or you can't feel the lymph nodes. But for breast cancer specifically, there's more of a staging here. And the worst case scenario is when you can actually feel those supraclavicular lymph nodes, because that means that the breast cancer has like really spread way more than we would want it to. But then the last kind of component to this is metastasis. And this is one of the things where it's like, well, either the cancer has left where it initially started or it hasn't, and it stayed where it is. Okay, and so there, like I said, these are the kind of the three things that we're thinking about when we initially start doing staging. How big is the tumor? What do their lymph nodes look like? And do they have any mets anywhere? Also, something that we talk about or think about is grade. So grade of a cancer is different from stage of a cancer. Grade talks about what the cells look like under the microscope. And so one is less aggressive, meaning there's less hyperplasia, the cells don't look dysplastic. And what that means is very fancy terms for essentially saying like, if it's grade 1, the cells look like kind of normal, right? They look like kind of normal. But if it's grade 3, the cells don't look normal. Like now they're dividing more than they should be. They don't have good ratios between their nucleus and their cytoplasm, and things just look odd, right? And so grade can help us kind of understand how the cancer might behave, but it isn't prognostic, not in the same way that staging is. So it's really the staging that kind of determines whether or not we think somebody's going to have a good prognosis versus a bad one. Okay, I'm gonna pause here just in case anybody has any questions quick. Okay, we'll keep going. All right. So another component of breast cancers specifically and their pathology is hormone receptor status. And that is largely because we know how heavily like hormone receptor expression, and so on and so forth contributes to how cancers behave. And we also have a lot of great medications, drugs now that we can use to target them. And so the three big ones that we look at for breast cancers are estrogen receptors, progesterone receptors, and HER2. And HER2 is kind of this like, it's a tyrosine kinase. It is involved in the RAS MAPK pathway, which is a growth pathway for your cell cycle. And again, like all of these kind of paint a picture of like how we think somebody's cancer might behave, as well as gives us an idea of like, do we need to add on a drug that's going to target this potentially, right? If I have a patient come in who has like a breast cancer that is ER positive, so estrogen receptor positive, I'm going to need to put this patient on a blocker of some sort or an aromatase inhibitor. And so the blocker that most people know is tamoxifen. Tamoxifen is the classic example of an estrogen receptor kind of blocker, right? The other thing that you do but we really kind of exclusively now use tamoxifen in premenopausal women because it targets a lot more of your estrogen receptors on like your ovaries, right? But in postmenopausal women, we actually use aromatase inhibitors, and that is because in postmenopausal women, the majority of what produces the estrogen in their body is actually your fat cells. So fat cells produce estrogen. And so because that's the main source of estrogen in postmenopausal women, we usually use aromatase inhibitors. But there are other medications, again, like I said, kind of that will target progesterone and HER2 as well, but estrogen is really the big one. And I put up kind of the pathway here as a sort of like callback to cell bio and biochem, which maybe some of you are in or have taken, or even if you've taken like a cancer genomics class or something like that, maybe you've seen this. But again, it's just to like demonstrate that these are hormone receptors. So all of their targets are actually intracellular. And tumors are just really smart. They're really smart at like making the rest of your body think like, oh no, I'm just a normal cell, or utilizing things that occur naturally in your body to help to grow, right? Okay, so we'll keep going then. Alrighty, the next thing that I just wanted to sort of briefly talk about here are kind of genetic disorders. And so there's a couple of them that are linked to causing breast cancer. The most commonly known one or well-known one are the BRCA mutations. It's BRCA1 and 2 that are kind of implicated in cancer. In breast cancer specifically, but they're also associated with ovarian cancer. And actually the genes are meant to be DNA repair genes. So they are meant to encode proteins that help with DNA repair. And so when they're mutated, they don't help with DNA repair. And so now you have a cell that can just divide how it would like, right? And can accumulate mutations because you don't have the necessary machinery needed to repair the DNA. The next syndrome I just wanted to bring up is called Lynch syndrome. It is a mismatch repair mutation. And so again, it's like usually when there are problems in people's DNA, right? Because cells are dividing all the time. Usually we have specific proteins and genes whose job it is to fix the problem, whose job it is to fix the wrong kind, wherever it went wrong in the whole process of replicating. But again, if you don't have those things, you can't fix it. And so then the cells gather all these mutations, and that is bad, right? Lynch syndrome specifically, you can see all sorts of cancers in, though. It is definitely not just cancer. You can see colon cancer, pancreatic cancer, thyroid cancer. You can see brain cancers, as well as things like endometrial cancer and breast cancer as well. So if you have somebody come in who has a prior history of cancer, especially if it's a weird cancer, you're like, ooh, maybe we need to test this person for Lynch syndrome. Okay, the next, oh, too far. The next thing to just briefly talk about is Li-Fraumeni. And Li-Fraumeni is a mutation in P53, which is big and bad. P53 is like the guardian of the genome. It's responsible for deciding whether or not a cell can continue through replication or whether it'll freeze it, right? So hopefully all of you are familiar with P53 because it's a big part usually of the central dogma of biology. But some people, believe it or not, can have it mutated. And as a result, can have all sorts of different cancers. And then the last one down here is just this PALB2 mutation. It is more associated with breast cancers than other cancers, but it is, again, a DNA repair change. So these are some of the things that are possible that people can be carrying around with them kind of unknowingly. So again, that's why we always ask about family history. We always ask about, prior health history, because there's the possibility that people are walking around with this. And if that's the case, then we want to test their family members and we can adjust screening timelines and so on and so forth to help catch it sooner. And you'll even have some patients, like our BRCA patients, if they have a known mutation, will do prophylactic mastectomies, right? Who don't have cancer now, but they have such a high risk of developing it in the future that they just want to take their breast tissue out now, right? And that's kind of the extreme, but it does happen. It is a possibility. Okay. So then talking about just briefly the treatment. So what do we actually do when somebody has breast cancer? And the first thing that we do is surgery, kind of definitively surgery. And you've really got two options. You can do a mastectomy and take all the tissue out, or you can do a lumpectomy and just take some of it, just like we think that it's about this size, and so we're going to kind of cut it out, and then we're going to send it to the pathologist and check the margins. So what that means is we're going to make sure that, along with all the cancer tissue, we take out a ring of healthy tissue as well, so that, we make sure we got it all, basically. Some people will then go on to receive radiation, and radiation is required if you are having a lumpectomy. So you can either have a mastectomy or you can have a lumpectomy and radiation. That's really kind of the two buckets that we fall into. And they are equally good as far as treating goes, especially if you have an early cancer. Most surgeons would say, please get a lumpectomy. I don't want to completely distort your breast and just do the radiation afterwards. And then the other kind of components, and some people are cured after that. It is truly just take surgery and radiation, and that's it. They don't even need to be on anything after that. However, frequently people will get put on it. And some of the mainstay of medication treatment for breast cancer is anti-endocrine therapy, because again, we know it's very hormonally driven. And the two big ones, like I said earlier, are tamoxifen, which specifically targets that estrogen receptor, and then the aromatase inhibitor, which I was also talking about a little bit earlier. And again, the difference between them is do I just prescribe it to somebody who's premenopausal, or am I describing it to somebody who's postmenopausal, and just weighing the factors on that decision. And then lastly, of course, is chemotherapy. When people hear cancer, they almost immediately think chemotherapy. But breast cancer, we actually rarely use chemotherapy nowadays. The indications for chemotherapy are things like really late stage disease. So somebody who has metastases, they need a systemic therapy like chemotherapy, or if somebody has what we would call triple negative breast cancer. And so that means they are estrogen receptor, progesterone receptor, and HER2 negative, which means we can't use any of our, super special targeted drugs, and we just have to do the big stuff, because classically triple negative breast cancer is the most aggressive. It progresses the most fast, generally is the hardest per se to cure, and has the worst recurrence rates. Okay, so then just briefly kind of wrapping it up with our patient's course. Miss L was diagnosed with stage 2, ER/PR positive, HER2 negative, invasive ductal carcinoma, right? So that means that she's probably stage 2 because her tumor was 3 centimeters. We learned her ER/PR status based on that biopsy that we probably took initially. And then we know she's invasive ductal carcinoma because it's kind of grown outside of the duct. It's no longer just inside the duct, right? So to treat her, she did what we would usually recommend for most patients who come in with early stage cancer like this. She underwent a lumpectomy and radiation and is continuing maintenance therapy with an aromatase inhibitor, again, because she's postmenopausal. And so her estrogen source is, again, her fat tissue. Right. And so we just inhibit the specific enzyme that's responsible for, creating the estrogen in her fat tissue. And she does not require chemotherapy. She will probably be on an aromatase inhibitor for about 5 years. So it's usually 5 to 10 years, right? And she will get serial breast exams. For the first 2 years, the breast exams alternate between usually the surgeon and the radiation oncologist, and it's every 6 months. So for the first 2 years, she'll get a breast exam, a clinical breast exam every 6 months. She'll get imaging. She'll continue to go and get her mammograms, very probably yearly. And then after the 2 years, she gets to graduate to yearly for a couple years. And then once we get to 5 years, that's kind of when we graduate people out. We say, you know what, you're looking pretty good. I think your survival is going to be great. We can sort of say goodbye. Because people generally, the most risk for recurrence happens in those first 5 years. Okay. These were my sources. Largely, it was just my curriculum. I did my surgical rotation on the surgical breast oncology service. And so I scrubbed into the mastectomies, I scrubbed into the lumpectomies. And so I didn't need to do a ton of searching to get this knowledge and information. Because I'd already had it from all my wonderful preceptors. However, I stole lots of images. And all of the sources are here. Sorry, they're not, formatted wonderfully, but if anyone needs any, feel free to reach out.